Neurology Quiz number 36. Describe clinical features, investigation, and treatment of spontaneous intracranial hypotension. Spontaneous intracranial hypotension occurs secondary to CSF leakage. Predisposing factors are hypermobility states such as Marfan's and Ehlers-Danlos syndrome that cause dural weakness and lead to diverticular and tears with CSF leakage. Osteophytes and disc spurs are other possible causes. Trivial trauma that could predispose to rupture of pre-existing dural weakness is reported by some patients. Headache is the commonest symptom and may start abruptly. It is usually bilateral, worsening with standing and improving with lying down. Exacerbating factors include coughing, sneezing, bending, etc. Straining or Valsalva maneuver may worsen headaches by exacerbating CSF leakage through the dural defect. The location and quality of headache can be variable and ranges from mild to incapacitating. The orthostatic component may disappear over time and paradoxical worsening on recumbency may occur. Patients can report migrainous features like nausea, photophobia, and phonophobia. Non-headache manifestations can occur probably due to traction on the brainstem and intracranial structures. These include third, fourth, and sixth nerve palsies, deafness, tinnitus, and vertigo, Parkinsonian features, and other movement disorders. Some patients can develop personality changes resembling FTD. Alterations in sensorium can be seen. Diagnosis. LP diagnostic criteria requires low CSF pressure, less than 60 millimeters of CSF. However, some studies have shown that only 30 to 40% of patients have such low pressures. MRI brain with contrast is very helpful in diagnosis. Findings are related to cerebral venous distension and descent of the brain. Veins distend more easily than arteries in the face of low pressure and cause diffuse pachymeningeal enhancement. Venous distension of the dominant transverse sinus with convex rather than concave shape and pituitary gland hyperemia. Downward displacement of the brain causes descent of cerebellar tonsils, posterior fossa crowding, flattening of pons, midbrain distortion and descent, and reduced midbrain pons angle. Complications of intracranial hypotension that can also be seen in the MRI include subdural hematoma, venous sinus thrombosis, subarachnoid hemorrhage, and superficial siderosis. The image on the left shows a coronal T1 weighted MRI with contrast demonstrating typical smooth diffuse pachymeningeal enhancement. And the figure on the right shows an MRI brain showing an enlarged pituitary gland and effects of brain descent/sag. Spinal imaging. CT myelography can be highly effective in detection of spinal CSF leaks. Iodinated contrast is injected into the subarachnoid space followed by whole spine axial CT. This allows visualization of CSF distribution and localization of CSF leakage. However, fast flow leaks can be missed, and another disadvantage is exposure to radiation. Conventional T2 weighted spinal MRI can only show indirect signs of leaks such as epidural CSF collection, distended epidural veins, and collapsed dura. Its utility is limited. Heavily T2 weighted MR myelography does not require contrast and can be used to visualize CSF leaks. It has been shown to be comparable to CT myelography. Digital subtraction myelography performed under fluoroscopy allows real-time visualization of contrast injected into the subarachnoid space, traversing the spine to identify the site of the leak. It has excellent resolution but is not widely available. This is a dynamic CT myelogram with sagittal A and axial B images demonstrating split contrast flow, the arrow along the site of the leak in figure A, and the arrowhead in B shows contrast accumulation in the epidural space. Radionuclide cysternography may show evidence of radioactivity at leakage sites. Indirect evidence includes radioactivity not extending beyond basal cisterns and lack of activity over the cerebral convexities. The ICHD-3 diagnostic criteria for headache due to low CSF pressure are given below. Treatment. Conservative measures that are utilized include bed rest, elevating the foot end of the bed, and hydration. Medications like caffeine, theophylline, analgesics, a 2 to 4 week course of corticosteroids, and bilateral greater occipital nerve blocks are also used. These are often unsuccessful. A non-targeted autologous epidural blood patch is the next step if the leak site has not been identified. With a success rate of 30 to 40%, it can be both diagnostic and therapeutic. A non-targeted blood patch is usually done in the lumbar area and 10 to 20 ml of blood are injected. The mechanism of relief includes direct compression of the dural sac and increased CSF pressure rostral to injection, compression and sealing of the leak, and preventing CSF leak into the epidural space. Benefit may require a few to 24 hours. If the leak site is identified, a targeted epidural blood patch with percutaneous placement of fibrin sealant is performed under CT guidance. Surgical approaches are considered if at least 3 epidural blood patches have failed. The tear in the dura can be sutured, meningeal diverticula can be ligated or sutured, and surgery can also remove calcified disc or osteophyte causing a dural defect.